Hello everyone. Today we'll be talking about other ways to help you decongest your patient in heart failure. Please view my earlier lecture on how to use diuretics to learn more. There are many RCTs in this lecture. Feel free to pause the video and look at the data or read the paper online. There are other ways we can help decongest these patients. Some of these mechanisms include blocking your ADH pathway, which results in water absorption, blocking your SGLT2 pathways, which is a sodium and glucose co-transporter, and stimulating your natriuretic pathways. As you know that the volume depletion is a stimulator for ADH production, and as your blood volume or pressure drops, rate of ADH secretion by your pituitary increases. However, you understand that the serum osmolality is main stimulator for ADH production, and we have discussed this in great details in my hyponatremia lectures. The drop in pressure from either volume depletion or forward failure in heart failure is sensed by carotid and aortic bodies, and this results in secretion of ADH from the pituitary. ADH results in increased expression of aquaporin channels in the distal convoluted tubule, resulting in increased free water absorption. This results in improving the volume depletion. However, it results in hyponatremia as well. This is one of the reasons why advanced heart failure patients develop hyponatremia, and the amount of hyponatremia will depend upon the severity of congestive heart failure. Hyponatremia has been associated with worse outcome in heart failure. Vaptans inhibit the action of antidiuretic hormone and can increase excretion of free water. So if you can block the ADH, you can certainly get rid of free water, and this may improve hyponatremia as well. One of the things that you have to remember is vaptans increase the excretion of free water, but not the salt. However, this drug has been studied for more than 20 years and not much benefit has been found to its use. Back in early 2000, tolvaptan was shown to reduce body weight, edema, and normalize serum sodium in hyponatremic patient with congestive heart failure. And you can see that tolvaptan of 30 was as good as higher dosing. So this was the dose used in subsequent studies. In the largest tolvaptan trial, which was the Everest trial, they compared tolvaptan with placebo in hospitalized heart failure patient. This was a large study, and they did find that the tolvaptan was better in achieving weight loss and urine output and dyspnea scores. However, it failed to achieve the patient-assessed global clinical status score. When they followed these patients for a long period of time, they figured out that tolvaptan has no effect on long-term mortality or heart failure-related morbidity. Another trial, Tactics Heart Failure Trial, found a similar result. They saw increased weight loss, increased urine output. However, it did not improve patient dyspnea scores. When they studied specific patients with hyponatremia in heart failure, they again found that tolvaptan does result in increased urine output and decreased body weight. However, the dyspnea scores were no different. When you look at the meta-analysis, you see that there is some improvement in overall dyspnea scores when you combine many studies together. However, you do not see any improvement in mortality or long-term benefits. So vaptan seems to have impact on urine output, weight loss, and dyspnea relief. However, they are not shown to improve mortality, rehospitalization, or overall well-being status of the patient. So let's understand what the difference is. In the studies that we talked about, there has been around 1 kilo weight loss in these patients with use of tolvaptan. Let's see how loss of 1 liter of free water versus 1 liter of isoosmolar fluid is different. In a 70 kilo man, 42 kilograms water is distributed between ICF and ECF. If you lose 1 liter of free water, you're losing free water from total water content, that's your 42 kilos. So the amount of free water that is lost is the proportion that is present in your intravascular plasma, that is 3, divided by 42, which is the overall distribution of free water. However, when you lose isoosmolar fluid, you are losing mostly from the ECF because sodium is present only in the ECF compartment. So the volume change in intravascular space when you lose an isoosmolar volume would be amount that is distributed in your intravascular compartment divided by your ECF. So you can see that the volume change in intravascular space is at least 3 times higher when you lose free water. And that's what the difference between tolvaptan and Lasix is. Lasix results in loss of isoosmolar urine, so it does not changes your sodium levels. However, tolvaptan results in loss of free water, so loss of around a liter of free water will change your sodium by 2 to 3 milliequivalents. However, it does depend on total body water, so it will vary among the patients. What if you compare tolvaptan with loop diuretics? Remember, one of them just removes water while the other removes salt and water. And in Aqua AHF trial, they studied furosemide versus tolvaptan. This was a small study, but they noted similar amount of diuresis. However, they did not report any changes in sodium or natriuresis in the study. Another common question to ask will be, will Lasix plus tolvaptan will be any better than Lasix plus thiazides, which we talked about in our previous lecture. And there's only one study which compares these two, that's a 3T trial, which compared oral metolazone, iviclothiazide, and tolvaptan, and it did not find any difference amongst them. However, it was a very small study. So hyponatremia portends poorer prognosis in CHF. However, hyponatremia is just a marker of severity of heart failure, and correcting hyponatremia with vaptans have not shown to improve mortality. It just corrects the number. Vaptans, however, have been shown to help with volume loss and decrease weight and possibly improvement in dyspnea scores. However, they have not been shown to improve mortality, rates of rehospitalization, or overall well-being of the patient. And possibly you can achieve the similar effect of urine output with thiazides. Tolvaptans are expensive drugs, and you can see the comparison, $4,000 versus $65 when comparing metolazone and tolvaptan. Other side effects of vaptans include rapid correction of sodium and daytime urinary frequency, and these cannot be used in CKD and ESRD patient. ESC Guidelines in 2022 do not mention this class of drug in treatment of acute heart failure. The next drug is necrotide. This is a human recombinant B-type natriuretic peptide. This inhibits renin-angiotensin system and sympathetic nervous system effects. It's also natriuretic and diuretic. So using necrotide may help decongestion with sodium and water loss. However, we understood from the previous lecture that in congestive heart failure, BNP is very elevated, but effect seems to be attenuated because of multiple reasons. This drug was studied in ASCENT-HF trial, and they found that necrotide was not associated with decreased rate of death or rehospitalization and was associated with increased rate of hypotension. In another study, Rose acute heart failure trial, necrotide did not enhance decongestion or improve renal function when added to diuretic therapy. It also did not increase urine output in patients with heart failure. So in acute congestive heart failure, necrotide is not used. There are other natriuretic peptides such as eularitide, which is a kidney-derived natriuretic peptide. This has been shown to improve pulmonary artery wedge pressure and right atrial pressures. However, we do not have any outcomes data on this medication. Sodium glucose cotransporter 2 inhibitors inhibit SGLT2 channel in proximal convoluted tubule, which supports your sodium and glucose. So by blocking the channel, you should be able to lose some of the sodium. However, natriuretic action of this drug is transient. This works mostly by osmotic diuresis. There are many other ways that it can help apart from diuresis, and I would suggest you reading this article to know other mechanisms. SGLT2 inhibitors have been shown to improve mortality in DAPA heart failure trial and Emperor trial. They have been shown to reduce rate of hospitalization and cardiovascular death. SGLT2 inhibitors are grade 1 recommendation, but let's see their use in acute CHF exacerbations. EMPA Response HF trial compared placebo with SGLT2 inhibitor and found that there was increased urine output and reduced worsening of heart failure and rehospitalization. However, when you read any study on heart failure or any other medical condition, make sure that you understand limitation of studies which compare multiple endpoints in one study. There's a term called p-hacking, and I would like you to read about it and be cognizant of this term. Impulse study was the largest study studying SGLT2 inhibitor compared to placebo. They found that SGLT2 inhibitor result in significant loss in body weight, and this clinical benefit was even evident at day 90. This medication helped patients regardless of their ejection fraction or presence or absence of diabetes. SGLT2 inhibitors are also beneficial regardless of the baseline renal function. they do not affect serum sodium or potassium significantly. So you can use SGLT2 inhibitors to increase urine output, improve symptoms, and improve long-term outcomes as a part of GDMT in acute heart failure. Mannitol is an osmotically active drug and does not cross cell membrane and blood-brain barrier, and has been used extensively in neurological literature. It acutely raises plasma and extracellular osmolality, resulting in increased circulating blood volume, which can result in dilutional hyponatremia. If the patient is compensated, it increases your stroke volume, cardiac output, and blood pressure. However, if you are unable to compensate, this may result in pulmonary edema and signs and symptoms of congestive heart failure. However, this has been not studied very well in the literature. When you search mannitol and pulmonary edema, you hardly get any result on PubMed. I could find only 2 case reports on this topic. There are a couple of studies which use mannitol and they have not found similar results. This one was published in Critical Care Medicine in 2005, which looked at your lung water content after being treated with mannitol and hypertonic saline. And you can see that the treatment with mannitol and hypertonic saline does not result in any more lung water content. There are few studies which have shown that mannitol can increase renal blood flow and can be cardioprotective. However, there is only one study that has used it in congestive heart failure. However, this was an observational study and has no controls. So, use of mannitol in congestive heart failure is still questionable. Another way to decongest would be using your gastrointestinal tract, and you can use substances that should be able to absorb sodium and water in your intestines. One of such medication is cross-linked polyelectrolyte. This is a polymer when given orally absorbs water and electrolytes such as sodium and potassium, and these are eventually eliminated in the feces. A randomized control trial in 2012 showed that there was improved body weight when using this compound when compared to placebo, and similar results were obtained when you looked at the dyspnea scores. However, this medication has not been studied since. In summary, you can use SGLT1 inhibitor to help you diurese and decongest better. This drug is also part of GDMT in heart failure, so is highly recommended. Usefulness of Vaptans is limited. Neseritide is not indicated in acute heart failure admissions, and other osmotic diuretics such as mannitol have not been studied for diuresis in congestive heart failure. These are the references. Thank you.